Hi everyone, my name is Priyesh and I'm currently QUESMED's Digital Teaching Fellow. Today I'm going to give you a quick tour on how to get the most out of our platform. So once you've bought a subscription and you've entered the QBank platform, the easiest way to start doing a set of unseen questions is hitting our Quick Start button. Then you'll see that for each question we have detailed explanations on why each answer is correct or incorrect, and we also have a page associated with each question. This goes into depth on everything that you need to know for that condition. Next, I'd like to show you our flashcards, and these are based on an AI algorithm which takes into account the questions that you've got wrong and need to learn further to produce a daily set of flashcards which you can then rate to then further help determine what you need to see on the next day. And as I mentioned, these refresh every single day. We have mock tests on our platform as well, including prescribing assessments. And as mentioned, we have a detailed knowledge library, which is a textbook covering exactly what you need to know for your exam for each condition. For example, acute coronary syndrome, where we have a summary followed by all the important aspects of the condition, including references at the end. We also have videos which cover tutorials as well as lectures. And just to quickly show you, we also have an OSCE which will cover the practical elements of your exams, including A to E assessments, communication skills, examination stations, and history taking stations. So for example, with each and every station, we can take them under timed conditions, and this is something that you can do with your friends where you can each take up a role and you can practice and go through them together. And for each OSCE station, we also have a walkthrough on how to approach that station as well. So that's everything that I wanted to cover today. That was a whistle-stop tour. If you have any other questions, please email us at info@quesmed.com, and I hope you found that useful. Thank you for watching.
Hello everyone and welcome to a PSP by MOGIG. This is our second of 5 that we're recording this year, and today I'm going to be talking about early pregnancy bleeding and obstetrics. My name is Mark, and this guide is going to be covering some of the prompt guidelines that you need to know for your end of year 4th year exams. So just before we get started, I'll just quickly outline what we're going to cover. This presentation is not going to cover the entire matrix. However, I wanted to cover some of the areas which I felt were confusing last year, and I've added some practice questions as well based on the prompt guidelines to help consolidate some of this information. So the first part of this presentation, we'll be talking a bit about early pregnancy bleeding, an approach. We'll talk a bit about miscarriage, pregnancy of unknown origin, ectopic pregnancies, and gestational trophoblastic disease. Then part 2 will focus more on later stage pregnancy issues such as Rhesus Isoimmunisation, preterm labour, PROM, PPROM, CTGs, malpresentations including breech, some of the manoeuvres you need to know for breech, what an ECV is and a little bit about that, a little bit about inductions, VBACs, perineal tears, postpartum hemorrhages, placenta accreta, vasa preva, and then finally cord prolapse. So let's get started. And of course, it's really important, as per usual, to acknowledge these are student-made lectures, so there may be mistakes in them. If you do find a mistake, please let us know on this email. And I'd also like to acknowledge William, who made the 2024 MOGIG Matrix Guide. A lot of the diagrams I've used in here and some of the content has come from his guide, so I just want to acknowledge him, and it's a really great guide you can access in our resources folder on the Google Drive. Alright, so here is an approach to bleeding in pregnancy. Broadly speaking, I found this quite useful to look at last year. You can divide bleeding up into pre-20 weeks and then after 20 weeks bleeding. And then the question then becomes whether the bleeding comes from the cervical os or not from the cervical os, and whether the cervix is open. I won't go through this too much now, but have a look at this, and then once we've covered some of the matrix conditions, this flowchart will become a little bit more useful. So what is early pregnancy bleeding? Well, this is pregnancy is bleeding, I should say, before 20 weeks gestation. And in the majority of cases, this is like a normal phenomenon that's found in live pregnancies and also can be from an implantation bleed in about 60% of the cases. In about 30% of cases, it occurs in miscarriage, in roughly about 9.5% in ectopic, and then more rarely, it can be because of gestational trophoblastic disease as well. And there's a few other differentials that we'll talk a little bit about as well in this presentation. But it's also important to remember that early pregnancy bleeding can be because of non-pregnancy related causes, gynecological causes such as polyps or cervical or vaginal trauma. So let's talk about miscarriages initially. What is a miscarriage? So a miscarriage is a spontaneous pregnancy loss before 20 weeks or an estimated fetal weight of less than 400 grams if the gestation is unknown. Another definition that's worth knowing is what a septic miscarriage is, and this is the same thing, but it also presents with peritonitis, fever, or a malodorous discharge, and it's an infection of that miscarriage. So one thing that is useful to know is the differences between the different types of miscarriages, and this is a really great table. So the two questions I think are useful to answer questions on miscarriage types are whether or not the cervix is open or closed and whether or not there's fetal heart activity. So those two things are the most important that will help to differentiate the stages. So I'll just go through these briefly. The first being a threatened miscarriage, and this is the kind of miscarriage where someone presents to the ED, they're worried about bleeding, but when they do a speculum exam, the cervix is closed and there's a reassuring fetal heart activity. So this is something where there hasn't been, it's not a miscarriage hasn't occurred, but it's sort of increased the risk of a miscarriage happening later on. An inevitable miscarriage is the process where the cervical os is open and the fetus may or may not have a heart rate, but because the cervical os is open, that means that there's going to be, unfortunately, it's inevitable, as the title says, inevitable that a miscarriage would occur. And given that this has just happened, there's no past products of conception yet. An incomplete miscarriage is, as it sounds, it's a partially expelled miscarriage. So the products of conception, in the question, they will be described them as half in the uterus, half out of the cervix. It will use a description like that. And of course, for that to happen, the cervical os must be open and the fetal heart activity won't be present, and there will be partial past products of conception. Then I guess the last stage of this spectrum of miscarriage is a fully expelled or complete miscarriage. In this case, the cervix usually will be open, but if it's fully complete and it's been a while, it may be closed again. There will be no fetal heart activity because the products of conception of the fetus will be completely expelled from the body. Now the last kind, which is a bit confusing, is a miscarriage. And this typically won't present with the clinical signs of bleeding or something like that. It's often discovered incidentally, where the fetus has died in utero, or the products of conception have no longer have a heart activity. The cervix is closed and there's no bleeding. So it's almost as though the fetus has died in the uterus and has not been expelled, and the cervical os is not closed and there is no bleeding. So this is what we call a miscarriage. So let's apply a little bit about what we have learned here and focus on doing some practice questions. So here's the first one. I'm just going to get you to read it and pause the video, and then we'll go through the answers in just a second. Okay, let's go through the answer. So the answer is that this is an incomplete miscarriage. So I think that the things that give this away is, on examination, the cervix is open and the products of conception are partially expelled, and there's no fetal heart activity. So because of this, this would fit into the incomplete spectrum of a miscarriage. Let's do another one. I'll get you to read this and pause the video and have a think about what kind of miscarriage this is. Okay, I'm going to go to the answer now. This is a complete miscarriage. So as you can see, the cervix is open, the products of conception are fully expelled, so therefore this is a complete miscarriage, and you can see here on this table. We'll do another question. So this patient, have a read of the stem and pause the video, and in just a moment I'll go through the answers. Now this is a missed miscarriage. As we said before, this patient hasn't presented because of concerns about bleeding. They've come for a prenatal visit. There's no symptoms of bleeding or cramping. The ultrasound shows a non-viable fetus with no clinical features, meaning there's no fetal heart activity. And because of that, this is a missed miscarriage. And this is our last question. Have a read, and then when you have an answer, you unpause the video and I'll go through the answers. Okay, this is a threatened miscarriage. So as we said before, this is a classic situation in a question where a patient presents to a provider, they have a vaginal bleeding and they're worried about a miscarriage. However, the cervix is closed and there is a fetal heart rate, a normal fetal heart rate. And because of that, it's a threatened miscarriage. So that a miscarriage hasn't happened yet, but it's an increased likelihood it will happen because of this incident. So then the question becomes, how does one diagnose a miscarriage? So the most important number you need to know is that you need to have a beta HCG of at least 1500, and I put that up here, before you can see anything on the ultrasound. So it's not possible to diagnose a miscarriage unless you have past products of conception, but you can't diagnose it on a ultrasound unless you have a beta HCG of 1500. Now, one of the mnemonics that I have worked on to remember is that doctors work 25/7. So that means that, so instead of 24/7, we made it 25/7. And that helps you remember the two main numbers you need, which is that a mean sac diameter of over 25 millimeters with no visible fetal pole, and secondly, a crown rump length of over 7 millimeters with no fetal heart activity. So 25/7. So there's a few other situations that probably are a little bit lower yield to know, but they're in prompt about when to repeat a transvaginal ultrasound. So for instance, if you don't meet that 25/7 criteria we've talked about previously on the last slide, and the mean sac diameter is over or equal to 12 millimeters, it's not at 25 yet, so you repeat it in 7 days. However, if it's less than 12 millimeters, the mean sac diameter, you will repeat it in 14 days. And then crown rump length, if it's less than that 7 millimeters, then you repeat it in 7 days. One thing as well is that if there are recurrent miscarriages, so more than 2, then it makes sense in a lot of cases to request histopathology of the products of conception and see if there are any causes that can be identified. So let's do a couple of practice questions now. Similarly, if you could read the question and pause the video. I'll get you to pause it now, and in just a moment we'll go through the question answers. Alright, I'm going to show the answers now. So in this case, we have a patient that has a mean sac diameter of 26 millimeters with no visible fetal pole. As we said before, looking at our 25/7, doctor's work 25/7, then this is indeed greater than 25, so it is a confirmed miscarriage. Let's do another question. So this patient has a crown rump length of 5 millimeters with no fetal heart activity. Is this a confirmed miscarriage? I'll get you to pause it, and when you're ready, we will look at the answers. So I'm going to show you the answers now. And the answer is no, this is not confirmed, and you need to repeat it in 7 days. So this comes back to this line. If you don't hit 5 millimeters of the crown rump length, then it's best idea to repeat it in 7 days to see what the findings are then. All right, another question with a crown rump length of 8 millimeters. Is this a confirmed miscarriage? We'll pause, and when you're ready, I will show you the answers. So I'm going to show the answers now. And in this case, given that it's 8 millimeters and it's above the 7 that we talked about before, then this would be considered a miscarriage. And here are some specific findings that are perhaps a bit lower yield, but still worth knowing. You start seeing, as we said before, a pregnancy on ultrasound at about 1500. The beta HCG needs to be 1500 or greater. The fetal pole arises around 5 to 6 weeks of gestation. The crown rump length, you would expect to see a fetal heart, is 7. The gestational sac size that you start seeing a fetal pole is 25. So that's where you get a 7 and 25 from. And at around 10,000, you start seeing a fetal heart rate. So there's a number of different miscarriage management options that we can talk about now. And they're broadly divided into expectant, surgical, and medical. So expectant management, we'll talk about this in a moment, but you need a patient that is hemodynamically stable. And this is more appropriate for patients that have incomplete or spontaneous miscarriages in the first trimester. In terms of surgical options, this is done with dilation and curettage, with pre-treatment of misoprostol, and medical treatment is available as well, but similarly this requires a stable patient. So let's talk a little bit more about the points we've raised on this slide. So expected management. As I said before, the patient needs to be hemodynamically stable, and this is appropriate for incomplete first trimester miscarriages. This is important that the patient is able to live close to a hospital to present, because they need to represent if they have excessive blood loss, pain, fever. This is indicating a septic miscarriage, or for some reason the products of conception has not been expelled after 4 weeks. Medical management is another one that is important to know. So in medical management, there are a few different things. So the first thing is that a patient is pre-treated with either misoprostol by itself or mifepristone and misoprostol. And the distinction is whether or not this is a missed miscarriage or not, as we've talked about previously. So if a patient has a missed miscarriage, they get a pre-treatment of mifepristone 24 hours before, and then, like all the other kinds, they get 4 doses of misoprostol, and that can be delivered via a number of different mechanisms. So I guess the most important part of trying to solve a question like this is trying to understand what kind of miscarriage it is and whether the patient is appropriate for this. So what kind of patients are appropriate for medical management? Well, we've already talked about the fact they need to be stable. Other contraindications include having a low hemoglobin, less than 100. If they have some bleeding disorder, if they have heart disease, severe asthma, COPD, adrenal insufficiency, or as I said, they live an hour away or more from a hospital. And the follow-up for a patient like this is weekly beta HCGs until they are negative. Now, surgical management is the final option, and this involves a dilation and curettage with pre-treatment of misoprostol given 3 hours prior. And just like with the medical option and the surgical option, it's also important to give anti-D within 24 hours of this process if the patient's appropriate. And we'll talk a little bit about Rhesus Isoimmunisation later in this talk. So surgical management is an option if their patient is heavily bleeding, if there's prolonged symptoms, a septic miscarriage, suspected gestational trophoblastic disease, if they've failed any of the previous management, or the patient has a preference for this. So this is similar to any other surgery. They have general anesthetic risks that they need to be informed of. There's a risk of perforation. There's a risk of Asherman syndrome. So this is when the patient can get some scarring and some surgical complications, which decreases the chance of fertility in the future. And the patient may bleed after this for 5 to 10 days. But surgical options are usually better for patients that are more unstable because the blood loss from a surgical miscarriage management is less than from medical approach. Okay, let's do a couple of questions having a look at the content previously. So I'll get you to have a read of this one, and when you want, just pause it and have a look at what the best option is for this patient. All right, we'll go through the answers now. So this patient wants to avoid surgery, but they have a missed miscarriage. And what are the best options? So as we've said before, that we need to pre-treat miscarriages with mifeprostone, and then they get 4 doses of misoprostol. So the answer here is B. Some of the other options are not relevant because they don't include misoprostol. Some of them have IV, which is not the given route. And this one here is incorrect because it's 6 doses. So the main things here are mifeprostone is given beforehand, and in addition, misoprostol is given for 4 doses as well. Okay, let's do another question. Have a read of this and let's select which is the most appropriate management. Pause the video and then I'll go through the answers. Okay, so going through the answers here. In this case, the answer is surgical management with D&C, and that's because the patient has uncontrolled asthma attacks, so minimizing the amount of misoprostol would be appropriate. And also the hemoglobin levels is 95, which, as we know, less than 100 is a contraindication for managing it via medical management. All right, let's go through a case. So this is a new topic. 28-year-old woman who is G2P1 presents to the ED with a 6-week history of amenorrhea, typical early pregnancy symptoms including nausea. She reports experiencing unilateral lower abdominal pain over the last 48 hours, which she describes as sharp and intermittent. Additionally, she has noticed her vaginal bleeding over the last 24 hours, which she describes as having a prune juice appearance. All right, so the answer to this is an ectopic pregnancy. So what is an ectopic pregnancy? So this is a pregnancy that occurs outside of the uterus and occurs in 1 out of 100 pregnancies. There are 3 outcomes. So some ectopic pregnancies resolve spontaneously as the ectopic is reabsorbed. Sometimes they become tubal abortions and they cause peritonitis because they extrude into the peritoneal cavity, and sometimes they can rupture as well. So in terms of risk factors to know, these are relevant in exams because some of these may be listed in the patient history, but some of the risk factors are tubal scarring, previous tubal surgery, ectopic pregnancy that's happened before, infection, IVF, smoking, previous C-section, and also interestingly a progesterone-only pill. This thickens the fallopian tube mucus and is a risk factor, a slight risk factor for ectopic pregnancies as well. So how does this patient present and what are the buzzwords? So initially the patient is asymptomatic, but around 6 to 8 weeks since the last menstrual period. The classic triad, which may or may not actually happen in reality, but is probably going to be what you see in a question, is amenorrhea, abdominal pain that's really on one side, and vaginal bleeding, and it's said to be described as a prune juice appearance. Some other buzzwords that you might see are tender adnexal mass and cervical motion tenderness or chandelier sign. So when you touch the cervix area on a speculum exam, it would be very, very painful. In terms of ruptured ectopic pregnancy, this is obviously more serious, and signs would be like hemodynamic instability, peritonism, and also bulging into the posterior fornix of the vagina. So, in terms of what the next steps are, bedside beta HCG is important to confirm an ectopic. So, without a beta HCG, you wouldn't have signs of an ectopic. Then you can start looking at quantifying the serum beta HCG. Obviously, if something doesn't double every 48 hours, like you would expect in an intrauterine pregnancy, this is a sign that it could be ectopic. And you can also look for serum progesterone if the beta HCG levels are not clear. In an ectopic pregnancy, this is going to be less than 30. In an intrauterine pregnancy, this is going to be above 30. And then you also have some of your standard bloods, but you should also consider a group and hold as well. Some other imaging that's important is the transvaginal ultrasound. Some of the things that would be noted on that would be free fluid, whether the uterus is empty, any complex adnexal masses, and any gestational sac, with this thing called the blob sign, which is you have an inhomogeneous mass that you'll see on the ultrasound, and it might be described as that in a question. So in terms of management for a patient such as this, some of the important things would be surgical and medical and expectant. So the first thing is a patient who is unstable, the answer is always going to be to do doctor's ABC first. So the patient's the emergency response is always more important than actually managing the ectopic itself. So if a patient is unconscious, not able to support their airway, that's going to be important. If a patient's not getting enough air, making sure they have oxygenation through bag valve mask or nasal cannulas, all these things are important that you would do before doing anything else. But broadly speaking, there's 3 different management methods. The first is expectant. Now these are quite, I think, rare. I don't think it's very often managed like this. But the criteria is that if a patient is pain-free and clinically stable, if the ectopic is less than 35 millimeters without a visible heartbeat, I should say, as well as a serum beta HCG less than 1500, and the patient's able to be closely follow-upped, that would be an appropriate candidate for expectant management. So now in terms of looking at medical management, the patient is given methotrexate and anti-D if they are rhesus negative. Some of the criteria for medical management is the patient has to have an unruptured ectopic and it needs to be less than 5 centimeters. The beta HCG needs to be less than 5,000. It needs to be less than 8 weeks gestation. The patient is hemodynamically stable. They're compliant with follow-up. No fetal heart rate. No immunodeficiencies or suppression. Pre-existing liver, renal, lung disease, etc. needs to be excluded. Once a patient has had medical management of methotrexate, the follow-up occurs on day 4, day 7, and then weekly until their beta HCG reaches levels less than 5, which usually takes less than 4 weeks. Now, given that methotrexate is teratogenic and causes defects in an embryo or fetus, then it's really important that the patient is advised not to get pregnant. Now let's talk about surgical management. So surgical management, there's 2 types, salpingostomy and salpingectomy. So given that most ectopics occur in the fallopian tubes, these are the 2 highest yield to know. A salpingostomy is the version that you see on the left, where they make a hole in the fallopian tube, remove the ectopic, and then suture it back together. And this is thought to be a good option if the other tube is lost or not functional, if a patient wants to maintain fertility in the future. Interestingly, after losing one fallopian tube, the level of fertility is roughly the same, it doesn't really go down that much. However, a salpingostomy can increase the chances of ectopic pregnancies in the future, and it's quite a complex procedure, so it is not likely to be done unless there's a medical reason why you wouldn't perhaps do a salpingectomy. Salpingectomy is when you remove the whole fallopian tube and the ligaments, and 99% of the procedure is done this way, and this is done if the other fallopian tube is healthy. And those are the two different approaches that you should know about surgically. Now let's talk about a case, and just have a think about what differential diagnosis you might come up with for this one. So a 28-year-old woman who's a G2P1 at 10 weeks of gestation presents to the emergency department with severe nausea and vomiting. She reports that her symptoms have been progressively worsened over the past 2 weeks, and on examination her uterus is palpated and be found to be significantly larger than expected for her gestational age. What are our differentials? So have a think about this. So you can pause, and in just a moment we'll go through the answers. So in this case, this is a gestational trophoblastic disease or a molar pregnancy. So in this case, a gestational trophoblastic disease is when you have a tumor of the placental tissue, and it usually occurs 1 out of every 1,200 pregnancies, the most common being a molar pregnancy. In this scenario, we had a classic presentation where the uterus was larger than the gestational size. The patient had hyperemesis, they were vomiting and had nausea, and it didn't say this in the case, but in this case, the patients have very high beta-HCG levels. Now, there's 2 different kinds, and we'll mostly focus on molar pregnancies under gestational trophoblastic disease. 2 kinds to think about: incomplete or partial moles, and this is when you have 2 sperm that enter 1 egg. So you can see an incomplete fertilization down the bottom here, and you see that what ends up happening is you have a normal ovum, so a normal egg, but 2 sperms fertilize it at once, or that sperm duplicates, and because of that, what you end up getting is this situation where you have a 69 chromosomes because of the number of sperm entering the normal ovum. The complete version is that when you have an inactive egg, so the egg doesn't have any chromosomes itself, but you are fertilized by 2 sperm. So in this case, you have 46 chromosomes and you have a complete mole. Now, one way to think about this is completely trophoblastic. So when you think about a complete mole, you can think about it having only the presence of proliferative trophoblastic tissue, and it has no embryonic or fetal parts. So completely trophoblastic. In this case, there's no possibility of developing into fetal tissue because there is no maternal chromosomes. A partial mole has the potential to partially develop. However, it's not compatible with birth because of the large number of chromosomes. So completely trophoblastic means that there is nothing but trophoblastic tissue, whereas incomplete or partial moles may have development may have embryonic or fetal parts. Now, one of the things I also mentioned before is that there are approximately 1 in 1,200 pregnancies occurs in this manner. Some other things that are useful to know here is that one thing is that you look at a complete mole and the most common is a 46, and this is usually because a haploid sperm has duplicated. It could also be a 46. A 46YY doesn't usually occur because it would be fetal, it would not be compatible, and it would be lethal, and it doesn't become a molar pregnancy. One thing you can also look at as well is the P57 tagging. So I put here that P57 is positive on a partial mole and P57 is negative on a complete mole, and this might be something you see in a question. And that's because P57 is found on maternal chromosomes. So obviously, because a complete mole is completely trophoblastic, it's going to have it's going to be P57 negative, whereas a partial or incomplete mole is going to be P57 positive. Now there are some other kinds of gestational trophoblastic disease which are worth looking at, but we'll talk about that in just a moment. One of the signs that you may see on ultrasound is the snowstorm sign, and this is going to be seen in a molar pregnancy. So, as I mentioned, there are a few different kinds of trophoblastic diseases. You have a partial mole here, and this might have some embryonic components to it, but as I said, a partial mole is not compatible with birth or life. A complete mole, and this is where you're going to have, as I said, it's going to be completely trophoblastic, and you can see in this situation how large it is and how high the beta HCG is going to be from this. And you can also see one of the characteristics is going to be multiple theca lutein cysts in the ovaries as well. So that might be a buzzword to be associated with a complete mole. An invasive mole, this is something that spreads a little bit more, and a choriocarcinoma is a malignant type of gestational trophoblastic disease, which we'll talk about in a moment, that commonly metastasizes. So here's a bit of a summary of what we've talked a little bit about, how the patient presents. They're going to have abnormal uterine bleeding, they're going to have a larger uterus than expected, they're going to have very high beta HCGs levels. Theca lutein cysts are going to occur in the ovaries. Because of that high beta HCG, there might be hyperemesis gravidarum, but there also might be nausea and vomiting. That might not meet that criteria, but it will be present. With severe features, sometimes preeclampsia before 20 weeks can actually be associated with a molar pregnancy, and hypothyroidism, just because the beta HCG has a similar mechanism to some of the thyroid hormones, and it's a molecularly very similar hormone. So you don't really need to know too much about that, but that's the link between hypothyroidism and driven by the beta HCG levels. Some of the risk factors, so in a STEM, the patient might have a high maternal age, and they might also, of course, like anything in medicine, if you've had a history of something, it increases your chance of having it again, usually. We talked about the snowstorm appearance and also looking at the beta HCGs, whether they're growing and the level it's at. Very high beta HCGs that are out of proportion are associated with molar pregnancies. The management is a dilation and curettage, and then the patient stays on contraception. We'll talk about that in a moment as well. So choriocarcinomas, so if you see a pregnant patient and the stem says something about cannonball metastasis to the lungs, you think choriocarcinoma. The way this works is because trophoblastic cells don't have transplantation antigens, so they don't have HLA or ABO. This allows them to escape from the maternal immune system, and they're able to invade into places like the maternal dessuda, vessels, and into the myometrium. From the myometrium, they go into the endometrial sinuses, and then they go throughout the maternal venous system. And because of that, they end up going throughout the systemic circulation, and they metastasize as tumors throughout the body. And that's what choriocarcinoma is. This is very rare, but it presents with shortness of breath, raised beta HCGs, and large amounts of theca lutein cysts again. So in terms of what the management is, the diagnosis is an ultrasound, and we talked about some of those features, the clinical features, and an abnormal beta HCG. Management is a suction evacuation. As usual, we consider anti-D if the patient is negative, and we also look at thyroid function tests, FBEs, group and hold, and a baseline beta-HCG for monitoring. As we said before, it's important not to get pregnant until advised, and to avoid using an IUD in that process because it can rupture the uterus. In terms of follow-up, partial mole, you have a weekly follow-up until the beta-HCG is normal. A complete mole needs to have the same, but then you need to have monthly checkups for 6 months. Now, the problem, as we've talked about before, is if these molar pregnancies do not go away after treatment and they become invasive or persistent disease, then this is a red flag. So a red flag would be that if you've had the dilution and curettage and it's been removed, then if your beta-HCG doesn't keep dropping or it stays at the same level, then it needs to be referred urgently to gynae-onc for consideration. And here's a bit of a diagram that's from Ramscog about how a gestational trophoblastic disease patient should be managed. But the most important things to know are that the patient needs suction curettage, they need regular follow-up, and red flags need to be monitored. Okay, let's do a few questions now about molar pregnancies. So the first one is, which karyotype is associated with a complete mole? We've got a few options here. Pause the video and then have a think about what the right option is, and I will run through the answer. Okay, hopefully you've had a think. And the answer for this is, I should actually say, you might actually notice there's two correct answers in this, 46XX and 46XY. So as we know, complete moles typically have a diploid karyotype. So usually they're 46XX or 46XY. And as we know, they result from the fertilization of an egg that has lost its nucleus by either a single sperm that's duplicated its chromosomes, or by two different separate sperms. And so hence the answer to this is 46XX or 46XY. Let's have a look at the next question. Which type of molar pregnancy typically has a higher beta-HCG? So let's pause and have a think about it, and we'll run through the answer. All right, so the answer to this question is that complete molar pregnancies usually have a much higher beta-HCG level compared to an incomplete or a partial mole. And this is due to the volume of trophoblastic proliferation. I'll show you, we'll go back a few slides. You probably remember this one we just went through. So this is the partial mole, and you can see it's quite a lot smaller, and this is a complete mole over here. So as you can see, a lot more a lot more trophoblastic proliferation, and it comes back to that mnemonic we had, which is completely trophoblastic. Okay, and let's look at the final question that we have, which is the imaging finding that's more characteristic of a complete mole? And we have fetal parts or a snowstorm pattern. And the answer to this question is that it's going to be the snowstorm pattern. As we know, a complete mole is completely trophoblastic, meaning there is no maternal chromosomes, therefore it will not have fetal parts, unlike perhaps in a partial mole. And we've already talked about a snowstorm pattern being characteristic of a molar pregnancy on ultrasound. So let's talk about Rhesus Isoimmunisation now. And this is when a pregnant woman with rhesus negative blood, the rhesus negative blood type, develops antibodies against rhesus positive fetal blood cells. And the way this happens is, as I said, the rhesus positive fetal blood cells enter the maternal circulation during pregnancy or childbirth, and they lead to an immune response. This is because in a rhesus negative mother, and when that mother is carrying a rhesus positive fetus, the immune system recognizes that rhesus positive cells as foreign. The parent, or the mother I should say, then produces antibodies against those cells. These are called anti-D antibodies. And in subsequent pregnancies, not that pregnancy, but the subsequent ones, these antibodies actually cross the placenta and attack any rhesus positive red blood cells of the fetus, leading to hemolysis and therefore a number of clinical effects. So this is a bit of a diagram here on the left which outlines some of these impacts, the maternal, placental, and the fetal impacts. So going back to first principles, throughout most of the pregnancy, the maternal and fetal blood do not mix. There are sensitizing events such as birth or in a miscarriage or in trauma when that is no longer true and blood can mix. And that is when we have this rhesus issue. Now, what is rhesus factor? Well, rhesus factor is the protein on the red blood cells. These are the antigens. So when someone says they have A positive blood or A negative blood, this is referring to their rhesus status. And it's the suffix on the ABO blood group. Now, as I said before, the rhesus D mother who has a rhesus D positive fetus will have a sensitizing event, I should say, and they will have maternal antibody production. Initially, the IgM antibodies will not be able to cross the placenta, but the IgG longer-term antibodies do cross the placenta and cause fetal RBC destruction. And that's why it doesn't affect the current pregnancy, but it may affect future pregnancies. Now, in order to overcome this, we give something called RhoGAM, and this is an immunoglobulin that's a prophylactic anti-D antibodies in rhesus negative individuals. So the way this works is that because we give this at various points during the pregnancy and during sensitizing events to a mother who's rhesus negative with a rhesus positive fetus, then if there is that blood crossing, the maternal and the fetal blood do cross, and that's called a maternal fetal hemorrhage. If that does occur, then those exposed rhesus positive blood cells are covered by this immunoglobulin and covered in it by these anti-D antibodies that we give the mother. So therefore they are quickly swept up, and the mother itself doesn't have an innate immune response to creating their own anti-D antibodies. So in a sense, by giving these immunoglobulins, we're providing artificial anti-D, and that will mean that there's not a sensitizing event as these cells are quickly mopped up and sent to the spleen. And that's how we prevent hemolytic disease of the newborn. And let's talk a little bit about that and the complications. So probably the way to think about this is prenatal and postnatal complications that are all related to the process of hemolysis when those anti-D antibodies go into the fetus in the second pregnancy or subsequent pregnancy. And the prenatal one is called hydrox fetalis, and this is a life-threatening condition. Notably, there's generalized edema and fluid accumulation. Pleural effusions also occur, and there can also be hepatomegaly, as you can see in this image or diagram on the side. And there's also postnatal complications. So for instance, because there's hemolytic anemia, there'll be low RBCs and hemoglobin. There can be hypoxia, jaundice, and kernicterus, which is when you have the bilirubin from the hemolysis of red blood cells builds up in the basal ganglia and the brainstem. And this can lead to neurodevelopmental issues such as cerebral palsy and hearing impairment. So how do we prevent this? Well, as we've talked about before, it's really important to understand if the mother has what her rhesus status is, and potentially we need to also look at her pregnancy history. So in booking bloods, we like to look at the blood group and also do red cell antibody testing to see if any anti-D antibodies exist already. And then at 28 weeks, according to PROM, the red blood cells are also checked in rhesus D negative women, again, to see if there's anything that has developed. And at birth, the baby's blood group is checked. We've already talked about giving RhoGAM, the immunoglobulin, at 28 weeks and 34 weeks. And in addition, it's given within 72 hours of birth. Now, we talked about how sometimes during pregnancy, where there's trauma, invasive procedures, other complications, there may be sensitizing events. And so because of that, we give this immunoglobulin within 72 hours of that. The other thing that's notable is there's something called a Kleinhauer test, and this is a test that will enable you to understand the amount of the fetal maternal hemorrhage and whether additional immunoglobulins need to be given. So what has PROM said about this? Well, PROM says that the guidelines are that you need to give 250 units intramuscularly for a singleton pregnancy in the first trimester. And if it's a multiple pregnancy, twins, triplets, etc., you need to give 625 international units. Beyond the first trimester, you still give 625 units, and at birth, a Kleinhauer is done to see if there is any more requirement for anti-D. There are some edge cases that are discussed in PROMPT, which are probably lower yield, but they're worth knowing if you're trying to get every single mark possible. If a patient has had 3 or more doses of 625 IU, they need an IV version of this called Roflec. That's a consultant-led decision. If it's not known, if there's isoimmunization, typically we don't give the immunoglobulins to women with anti-D antibodies, meaning they already have anti-D antibodies developed, because it wouldn't really do anything because the isoimmunization has already occurred, except for the administration of anti-D when the antibodies have developed with that. So, for instance, it may be that it's not clear where the anti-D antibodies have come from. Have they come from the fact that someone has been given immunoglobulins this whole time, or is it because they have innately made their own anti-D because of a sensitizing event? And PROM says that's a consultant-led decision. And also, if a patient has ongoing bleeding throughout their pregnancy, then this is a case where they would need to be given immunoglobulins every 6 weeks. So it's a little bit confusing, but it's worth getting your head around a little bit of this information. And we're going to do a couple of practice questions just to see if we can consolidate our information and apply it according to PROMPT guidelines.
Okay, let's go through this question. A 30-year-old female pregnant woman is at 13 plus 6 weeks gestation and presents with vaginal bleeding. She's Rhesus D negative. What is the appropriate management for this patient? Pause the video, and when you unpause it, I'll go through the answers. Okay, and the answer for this one is B. Because this patient is in her second trimester, the criteria says that she should have 625 units, international units. Okay, let's do another question. This patient is a 30-year-old pregnant woman at 9 weeks singleton gestation. And I'll pause the video. And we'll go through the answers. All right, and the answer is 250. And that's because it's the first trimester. Okay, let's now talk about preterm labor. So preterm labor is defined as labor that occurs before 37 weeks of gestation. It happens to about 5 to 10% of pregnancies, and it accounts for around 75% of perinatal mortality. Now, the diagnosis is difficult because a lot of times people can present with uterine contractions, and this is not actually always associated with cervical dilation, and about 50% of these spontaneous contractions actually don't proceed to labor. So it's important to have a process to know when someone is actually entering preterm labor versus when they are having contractions that may not result in preterm labor. So one of the criteria that can be done is looking at a fetal fibronectin, which we'll talk about in a moment, of over 50, checking to see if there's any cervical dilation. A patient that has a measured cervical length less than 15 millimeters and hence is at a higher risk because of their shorter cervix of preterm labor. or if there's actually ruptured membranes, or if the contractions are regular and painful. So I won't go through this slide, but this is the approach to clinical evaluation and the investigations that are required. One high yield thing to know about, which we talked about just briefly, is the fibronectin. So as I said before, when women come to the labor ward with signs of early labor or preterm labor, up to 70% of these people won't actually give birth that visit, and about 50% of those people will go on to deliver at full term. So to figure this out, to really differentiate preterm labor, we use a test that measures fetal fibronectin levels in the cervicovaginal fluid. This is a glue protein that acts as a glue between the mother's tissues and the fetal membranes. So if we find FFN between 22 and 36 weeks of pregnancy, this can predict that a woman is likely to deliver early in her pregnancy, and a negative FFN is a very reliable way or is a very good negative predictive value. So if the FFN is quite low, then it's unlikely that they need to be admitted. And you can see here low numbers versus higher numbers. And it's also important to remember that you shouldn't do a fetal fibronectin on a patient that has heavy PV bleeding, is already dilated beyond 3 centimeters, as that's probably evidence they're already starting labor, or has ruptured membranes. So these are contraindications of it because you really don't need it to show the risk of preterm labor, and it wouldn't change management because they are greater evidences of preterm labor beginning. Okay, let's now talk about preterm labor management. So depending on how early the preterm labor is determines the management. So before 22 weeks, it's thought that the pregnancy is not viable. Between 22 to 24 weeks, this is called the zone of parental discretion. And so if the patient's in this range, some things that can be done are considering steroids and magnesium sulfate. And also the criteria here is that there's no severe fetal growth restriction, no PPROM, no chorioamnionitis, and also usually there's a requirement to be born in a perinatal center or to arrange to be transported to an area where that support is. And then after 24 weeks, it's active pregnancy management. This is a really great diagram, a little bit higher up here on the slide, which shows you the timelines and which overlap with each other. For instance, corticosteroids are given between week 24 and week 34 and 6 days. Magnesium is given between 24 and 30. Tocolysis occurs between 24 and 34. And we'll go through what each of these are and what they mean, but this is a good diagram to understand, and it's from the MOGIG matrix guide. So in terms of preterm labor management, let's talk a bit about that in a bit more detail. So starting with corticosteroids, for preterm labor, the management is intramuscular betamethasone that's given at 11.4 milligrams, given twice, 24 hours apart. And this treatment is given, as I said, between 24 and 34.6 weeks of gestation, and its role is really to promote fetal lung maturation, and the aim really is to give birth within 7 days of the last dose. And tocolytics, which are the other drug as well, can be given to slow down the birth in order for those corticosteroids to become more effective. So tocolytics are drugs that are used to delay labor in pregnant people less than 34 weeks and who have intact membranes and are suspected they're going to give birth within the next 7 days. And in Monash prompt, the first line treatment is oral nifedipine with oral indomethacin as the second line. Now, talking a little bit about what nifedipine is, this is a calcium channel blocker, and these are L-type selective calcium channel blockers. So calcium channel blockers are effective at blocking uterine contractions and hence slowing down labor and delaying that process. And as I said, they can be effective in making sure those corticosteroids have enough time to work. Now, the second final point I wanted to make was on neuroprotection. So in preterm labor, it's very important to prevent cerebral palsy. And by giving magnesium sulfate, various studies have shown that giving this between 24 and 30 weeks is expected to prevent neurological issues that are associated with preterm birth. In Monash prompt for patients who are group B strep positive, you can have group B, and in this case, IV penicillin is given at a dose of 3 grams initially, followed by 1.8 grams every 4 hours after birth. So just to recap, the things you need to think about for preterm labor are steroids, with IM betamethasone being the first one that would be given, and that's between weeks 24 to 34 plus 6. Antibiotics for patients that need group B strep prophylaxis, tocolysis, most likely nifedipine, and neuroprotection, magnesium sulfate between 24 to 30 weeks. So that's a lot to remember, and there's actually a really good diagram here that's in the MOGIG guide that's helpful, and it's the statin management of preterm labor, where you have steroids, antibiotics, tocolysis. They have a letter for intrapartum, meaning that you need to have continuous CTG, notify pediatrics, and also neuroprotection as well. So giving magnesium sulfate to prevent cerebral palsy, or reduce the risk of, I should say, cerebral palsy, and the preservation of gross motor function. Of course, some of the other things that might be useful to know for an OSCE are things that can reduce the risk of preterm. We know that cervical cerclage or progesterone therapy can be useful prophylactically if the cervix length has been measured at less than 25 millimeters. We also advise patients to not smoke and to not use drugs during pregnancy. We try and manage and monitor for hypertension during the antenatal visits and treat asymptomatic bacteria and infections during pregnancy. So let's do a few questions related to the diagnosis and preterm labor. So we've got a bit of a match situation here where we've got 3 questions here on the side, and we've got options from A to H about how you would manage these. So which of these has a high negative predictive value for detecting preterm pre-labor rupture of the membranes, or PPROM, which we'll talk about in a bit later. Second, this is something that may allow a window of opportunity for antenatal steroid administration or intrauterine transfer. This one is contraindicated in the presence of vaginal bleeding, contractions, or infection. So we can pause the video here and then we will go through the answers. Okay, hopefully these look a little bit like what you wanted to see. So the first one is, this has a high predictive value for detecting preterm pre-labor rupture of membranes, and this is nitrazine. So nitrazine testing, it actually uses the alkaline pH of amniotic fluid, which is different from the vagina, to test for the rupture of membranes. There are many reasons, of course, that you could have a false result, but it has a high negative predictive value to help rule out whether the membranes have ruptured. The second one is, the answer is tocolysis. So tocolysis has no significant effect in prolonging a preterm pregnancy to term. So it's not something that you can just give and have months and months or weeks and weeks of prolonged pregnancy, but it can buy you a few more days, which can allow you to either transport a patient to a larger tertiary center, or it can also assist you with having the ability to give magnesium or corticosteroids. And the final one is, you can't give a cervical cerclage in the situation where the patient has vaginal bleeding contractions or infections. So this cervical collage is given as a prophylactic measure, just like a progesterone pessary or progesterone implant is given throughout the labor to prevent or to reduce the chance of preterm delivery. So it's not something that can be done acutely. All right, fantastic. Let's do some risk factors. The same thing. We've got 4 different risk factors and a number of different options here. The first one is the risk of preterm labor due to uterine overdistension. The second one is linked to recurrent episodes of threatened miscarriage early in pregnancy. The third may require surgery during pregnancy with associated risk of preterm labor. And the fourth is modifiable risk factors for which help and advice can be given in antenatal clinics. So if you pause the video now, I will go through the answers on the next slide. Okay, here are our answers. So for the first one, the main risk of preterm labor in multiple gestations is going to be overdistension of the uterus. So because there's multiple fetuses, and they will cause the uterus to be overdistended, which in turn increases the risk of preterm labor. The second one is intrauterine bleeding, such as a subchorionic hemorrhage, is an irritant to the uterus, and it can actually contribute to abdominal pain and bleeding as well, and can be associated with risks threatening miscarriages early in pregnancy. Appendicitis can occur during pregnancy, and smoking is something that should be advised to not do during pregnancy. PROM is very similar to labor, except it's when your membranes rupture without the labor part. So this is something where the babies came on time, so it's after 37 weeks, the baby's at term. However, the waters break, but there are no contractions. And this is defined as prolonged when it has happened over 18 hours. And it's diagnosed on history. A sterile speculum examination, provided you know where the placenta lies. And you can also use amnisure. The incidence are that about 60% of these patients go into labor within 24 hours and 85% within 48 hours. However, you always need to balance the risks up of cord prolapse, cord compression, placental abruption, chorioamnionitis, and endometritis about whether or not these patients are managed expectantly or they are induced to go into labor. So here's basically what I said according to prompt, and that really comes down to a discussion about the benefits and risks of active management with an induction of labor compared to expectant management where the patient waits until they start labor. The problem is, of course, that if there are a lot of risk factors, like the patient is GBS positive, they previously had neonatal GBS, if they've had a UTI, if there's meconium liquor, if there's abnormal CTGs, any of these risk factors would move you more towards active management, which is that you usually will try to give oxytocin to induce the labor, and you would be giving antibiotic prophylaxis as well if you are GBS positive. But if you are unknown, then you can still consider it as well. And then also there is expectant management on the other side of the spectrum when there's low risk, where you can wait up to 96 hours or earlier to start an induction. And as you can imagine, if the membranes are broken, then sitting around the hospital for too long is a risk factor for getting chorio and other issues that come along with that. Now let's talk about PPROM. So PPROM is another one on the spectrum, but this happens when it's before 37 weeks, the membranes have ruptured, so the water has broken, and there's still no signs of labor, so there's no contractions or cervical dilation. This is thought to have happened because of infection or inflammation, but the real reasons aren't really known. Some of the risk factors that might be in a question would be things like the patient has had this happen before, they've already had established risk factors for preterm labor, or they've had a preterm labor in the past, they've got an infection, a smoking history, a shortened cervical length, a low BMI, or they've had multiple pregnancies. So in this situation, what ends up happening is that the patient needs to be assessed, and if it is over 28 weeks, they can have a CTG. If it's less than 28 weeks, a biophysical profile. The confirmation of the diagnosis is usually done via history, but if not sure, PROM says that you can use a sterile speculum and you can use bedside ultrasound to assess amniotic fluid index, which by doing that would allow you to see the smaller amounts of amniotic fluid that would allow you to assume that some of it has been lost because of PPROM. So here is a flow diagram from the MOGIG guide about how PPROM can be diagnosed. As I said, usually it's a clinical diagnosis. So if you see liquor straight away, you can diagnose PPROM, but if not, you can do a sterile speculum. You can use RUM+, which is the PROM test, which looks for alpha fetoprotein, and you can also see if the patient, because you did an amniotic fluid index, if they have a lot of amniotic fluid, that would make it unlikely for it to be PPROM because none of it has been lost through the membranes. So that can help exclude it if everything else is also negative. If they have low amounts, if they have oligohydramnios through the amniotic fluid index, which is the ultrasound they do at the bedside to detect that, then you can't really exclude PPROM. So this is a good diagram to understand this process and really understanding that PPROM can be diagnosed by seeing LICOR or by doing some bedside tests or doing a physical exam or by relying on ultrasound findings. So once again, let's talk about how PPROM is diagnosed. There's a wonderful diagram that MOGIG has published this year, which talks a bit about PPROM. Once again, it's the same thing for preterm labor. If it's before 22 weeks, it's likely going to be pre-viable, and it's really about figuring out discussions about how the fetus will be delivered. If it's between 22 to 24 weeks, it's in that zone of parental decision, and over 24 weeks, it's viable. Then the question becomes, are there any risk factors? And they're very similar to the previous risk factors we've talked about before for PROM, which is, does the patient have chorioamnionitis, abnormal CT, meconium stain LICOR? This basically means that the fetus has defecated in its amniotic fluid, which is a risk factor as well. And so some of these things are really, and established labor as well, these are all risk factors. So if we have these things, we need to figure out whether we are going to expedite the birth or whether it's better just to wait a little bit and understand the risks of sitting around with open membranes without starting the labor process, which obviously can cause issues with infection, etc. So expectant management, the patient needs to be admitted for 3 days, at least 3 days, and they get regular surveillance, and they try to keep them there, try and keep them there to about 37 weeks, and then they can do an induction of labor. If there are a lot of risk factors and active management is required, an induction of labor is done to minimize the risks of PPROM. So PPROM is very similar in a lot of ways to PROM. Some of the things that are a little bit different though, steroids are given between 24 to 34 weeks for lung maturation. Antibiotics, prophylaxis is now azithromycin. That's for prophylaxis if the birth isn't imminent. So azithromycin is given after 24 weeks. if the birth isn't about to happen. If the birth is imminent and PPROM, or if there's going to be an induction of labour, then IV benza penicillin is given just like preterm labour. In terms of intrapartum, the same things apply. You need to have a continuous CTG. You need to have notified pediatrics. In addition, there may not be a role for a lower uterine segment, and so a classical cesarean may be required depending on how early in the process this is, because the lower part of the uterus is often the last part of the uterus to develop. And then neuroprotection, as per usual, we give magnesium sulfate at 24 to 30 weeks, and if we suspect birth, that's if we suspect birth within 24 hours. One difference between PPROM and preterm labor is we typically don't give tocolytics because we don't want the patient sitting, waiting around without starting labor, as this could cause the risk of chorioamnionitis and other sorts of infections to happen. The only exception to this is if we need to transfer the patient to a tertiary center. Okay, let's now talk a little bit about CTGs that are used in intrapartum fetal heart rate monitoring. So there are three kinds of decelerations and accelerations that we should cover, and these are late, early, and variable decels. So the first thing is that early decels are symmetrical to the contraction. So you should be able to see that the peak, the bottom peak here, which is called the nadir, they are symmetrical, or the lowest point lines up with the contraction. They generally occur taking 30 seconds or so to reach the onset to the nadir, so they're quite long. And these are usually caused by fetal head compression, and they're kind of normal and nothing to particularly worry about as of themselves. The next is that we have late decelerations. So as you can see, a contraction has occurred here, and these start after the contraction has begun. So the nadir is quite late after the contraction. They also take 30 seconds or more to reach the lowest point. And late decelerations can indicate a number of issues like utero-placental insufficiency, and that basically means that the placenta isn't getting enough oxygen to the fetus or the baby. Variable decelerations are at the bottom here, and these happen with or without contractions. They start and drop very quickly, and usually they're due to things like cord compression, low amniotic fluid, or sometimes cord prolapse. And they usually last between 15 seconds and 2 minutes. So understanding these patterns and these three kinds of decelerations is really important to being able to look at a CTG in an exam and say whether or not you would take a certain action in management. Let's have a look at an easy way to understand these that I found helpful in fourth year. So this is this veal chop mine mnemonic, and it sort of helps you sync up in your head what each thing on the CTG actually means. So a variable deceleration, so first of all you write down veal on one side and chop on the other. The variable deceleration is caused by cord compression, and often the solution to this is to put the mother onto a different side or reposition her. An early deceleration is usually a head compression, and it can identify labor progress. You can identify labor progress by having a look at the CTG and examining the patient, but this can also be not a bad finding. Accelerations are okay and no interventions are required. Late decelerations often mean placental insufficiency, And this is where intervention is required because this is a concerning sign. So veal chop is a useful way to remember the different causes or different acceleration or decelerations on a CTG. One of the other ones you're probably very familiar with is an approach to a CTG. So if you had a OSCE, it would be DOCTOR, which stands for define risk. C stands for contractions, and you're looking for 4 to 5 every 10 minutes. Baseline rate is the BRAV, and that's 110 to 160 beats per minute. Variability is 5 to 25. Accelerations, are they present? And D is, are there any decelerations? Are they absent, early, variable? And we've talked a little bit about those already. And then finally, overall, what is the impression, whether it's reassuring or not? So some things that can be conservative management options if you have, before rushing off to a C-section, I suppose, is putting the patient in a left lateral position because this takes the pressure off the IVC. If the patient has had an epidural, consider epidural-induced hypertension and give IV fluids. If the patient has been induced and the CTG shows excessive uterine contractions, then this is something where you may need to consider tocolysis. If it's unclear on what the CTG is showing, a fetal scalp lactate a fetal scalp sample with a lactate can show you whether or not you should do an urgent C-section or you should consider more conservative measures and reassessment. If there are lots of late decels and it's very obvious, you would not do this because a fetal scalp sample could take 30-40 minutes to actually even do, and by that time it might be too late in order to action on some concerning CTG findings. This is more something you do if you are unsure between what the CTG actually meant. So let's do a CTG question now. I will get you to read this question and pause, and then we will go through the answer. Okay, let's do a quick question on CTGs. So which of the following features should help reassure a doctor that this is a normal or reassuring trace? Have a look at the answers and pause the video, and in a moment, when you unpause, I will go through the answers. Okay, let's look at the answer to this question. The answer is C. So let's run through why the different options are correct or incorrect. So the first is that the baseline heart rate is 100 beats per minute. This is incorrect because a normal fetal heart rate at term is about 110 to 150 beats per minute. So that is a little bit low. Obviously, this question would depend on the duration or the gestation of the pregnancy. B, the baseline variability is less than 5 beats per minute. So remember that the baseline variability is a reflection of the normal fetal autonomic system. So at term, baseline variability should be greater than 5, and if it's less than 5, it's considered low or reduced. So that would not be a reassuring finding. C is the correct answer because accelerations, as you saw in the veal chop mnemonic, they are good. And the presence of 2 or more accelerations on a 20 or 30 minute CTG defines a reactive trace. D, there is no significant accelerations. As we said, accelerations are a positive sign. And E, the CTG is picking up regular contractions. This doesn't tell us what kind of contractions they are. It doesn't show us what decelerations or accelerations are going along with those contractions. So it's not the sign that we would be looking for. Let's talk now about malpresentation, and let's start off by talking about breech. There are a few different kinds of breech presentations, and this is defined as a presentation where instead of the head being the presenting part, instead you have the buttocks or feet or a combination of those. So in a frank breech, which is the first one you see on the left here,
you can see that the baby's buttock is aimed at the birth canal with legs extended straight up towards the head. With a complete breech, the baby's buttocks are aimed at the birth canal with both hips and the knees flexed. And a single footling and a double footling is when one of the baby's legs are extended downwards, so the foot is positioned to come out first, which is different to these ones where the feet isn't the first presenting part. So all of these are breech deliveries, and the way to manage breech we'll talk about in a moment, but sometimes in certain kinds of breech they can be delivered vaginally. So the most common would be a frank breech, and because of this, the extended legs can actually make a vaginal delivery more challenging. Complete breech over here is very similar with the buttocks leading, and once again a double or footling breech is when you have one foot presenting first. Now, as I said, most of these present and are found on ultrasound, but also via palpation in the exam. And ECV, or external cephalic version, can sometimes be used to turn a breech presentation around to put the baby head in a head down position. And we'll talk about this a little bit later, but cesarean section is usually recommended to avoid complications associated with a vaginal breech delivery. So these are the breech types, and they're worth knowing. Now, in terms of cephalic presentation, let's talk a little bit about that. So just because the head is down, that doesn't necessarily mean that the baby is able to be delivered, I should say, vaginally, or will be in a good position to be delivered vaginally. So let's talk about the three different kinds, and they have a few names. So vertex presentation is the most common, and this is called suboccipitobregmatic, and we'll come to the breg part in a second. But this is when the head is flexed, so the chin, see how the chin here is in contact with the baby's chest, and the presenting part is the posterior fontanelle over here. The other type is a face presentation on this side, and this is known as a submentobregmatic, or face, and you can see that the face is the actual presenting part because the neck is extended, and so the occiput is actually in contact with the fetal back, so it's very close to touching. The face is the presenting part, and as I said before, this can be diagnosed during palpation, while you're palpating the face on a vaginal exam or by ultrasound. Now, the brow presentation is when the brows here are the first thing that present. This is actually the most difficult to deliver because the diameter across is actually 13.5 centimeters, whereas both of these have an actual smaller diameter of the head moving through the birth canal, or through the cervix, out of the uterus, I should say. And because of that, these brow presentations are usually not deliverable vaginally. So the only two of these cephalic presentations that are deliverable vaginally are the suboccipitobregmatic, or vertex presentation, or the face presentation, which is submentobregmatic. They're both 9.5 centimeters in diameter. The good way to remember this is you can either remember vertex and face, which is, I think, pretty easy to remember, or if it's presented in the exam, you can remember the ones that are vaginally deliverable with breg in them, and that's why the mnemonic is breg is best. So we've already talked about breech presentations, but this is very high yield to know. So as we said before, just make sure you're comfortable with the different kinds. Now, in terms of managing malpresentations, we'll talk about ECV, which is the external cephalic version, where you try to spin the baby around to present to the right presentation, so it's head down. Vaginal delivery is possible only in frank or complete breech only. The patient has had only if the patient's had no previous C-sections, And as long as the baby isn't too small, less than 2 kilos, or too big with macrosomia over 4 kilos. A C-section, the evidence shows that this is the lowest risk of complications if the procedure is elective, and it's recommended to be done at 39 weeks. And the persistence of the breach must be confirmed by ultrasound on the day of the C-section. So one of the things that you might get asked and that is taught is the breach maneuvers. I found these a little bit confusing last year, and I'm not going to spend the time trying to explain exactly the steps you have to do. I think that would be quite a difficult thing to learn and to be assessed on. But I think it is useful to know what the maneuvers are and what their indications are. For instance, the Pinard maneuver is used if the knees are extended in breech. The love set is used if the arms are extended behind the neck, and the MSV is used to deliver the baby's head. So here are some mnemonics that I used last year that I made up to help you remember the different names of the maneuvers and how they work. So the Pinard is quite easy to remember because if you just remember, Pinard pins the knees. So if the knees are extended like this and not flexed, you use the Pinard maneuver. So I just think of some knees pinned together like this, and they're standing up, so therefore they're extended. The next one is the love set. Now this is a presentation where it's used if the arms are extended behind the neck. And the way I kind of think about this is the baby is a little bit like a superhero. And if the arms are extended behind the neck, it kind of looks like a Superman flying. So I remembered, we love Superman. We love set Superman. So if the arms are extended behind the neck, you use the love set maneuver. And the final one is the MSV. And this is, the way I remembered this is because you use it to deliver the baby's head in breech. Then the word for head is vertex. Move the small head. Move the small vertex. Move the small vertex is MSV. And that's the way I remember them. So let's just quickly recap them. So we have Pinard, when the knees are extended because you pin the knees. We love set Superman, because this is the position where the baby will have its arms extended behind the neck. And then we also have finally MSV, and that's move the small vertex because you're using it to deliver the baby's head. So let's do some practice questions about breech presentation. So let's match these breech presentations across with these definitions. Pause the video and we'll go through the answers. So I've matched the answers across here, and it's important to remember that breech presentation can be extended, flexed, or in footling position. Only in a footling breech does the foot present below the breech. A transverse lie is defined as a lie that's perpendicular to the maternal long axis, which is why the second answer is transverse. An oblique lie occurs when the angle of the fetal to the maternal axis is closer to 45 degrees. Now, when a fetal lie is unstable, meaning that the longitudinal axis of the baby relative to the mother still fluctuates and moves around at term, there is a risk of cord prolapse if the membranes rupture. Hence, women are routinely admitted to hospital at that term. An external cephalic version also can be used to turn a breech to cephalic presentation, and it works about 50% of the time, which is why the answer to 4 is E. And that's the position that we're taking a baby from one position and moving it into cephalic. So just a little bit about ECV. This is done where the head is manipulated and the bottom of the baby, and it's moved forward in a circular motion and repositioned. Some things to know, I guess, are useful. I won't go through all those things on this slide, but it's useful to know to avoid eating and drinking. Grip and hold is required. CTG is required before and after. Terbutaline is used to prevent preterm birth. and obviously you need to administer 625 units of Rogram to perform a Klein-Howard test afterwards. If a ECV is not successful, then it's time to have a discussion about whether a C-section is the correct way to deliver this breech. And here are some important contraindications that might be listed in a question about why you can't have external cephalic version. For instance, you wouldn't be doing this on a ruptured membrane, so this is not appropriate in something like PROM. In addition, you can't do ECV if you have twins or greater numbers, and if there's oligohydramnios, for instance, there's low amounts of amniotic fluid. These are all reasons, and obviously very importantly, placental abnormalities. So you wouldn't do this if you had placenta previa or you had placental abruption or history of placental abruption. So now let's talk a little bit about induction of labor. So what is induction of labor? So induction of labor is when you want to start the labor process, but labor itself hasn't started. There's a difference between induction and augmentation, and this can sometimes get a bit confusing because some of the similar drugs are used for both. But induction, as I said, is when you start labor off without it actually having naturally occurred. Augmentation is that once you have started labor, then you can stimulate the uterus to contract more after that process has started. Now, we calculate a Bishop score. Now, we've been told in the past that you don't need to memorize the components of a Bishop score, but it is useful to have like a mnemonic around what the numbers mean. So the mnemonic I've heard is below 5, the baby can't arrive. Above 6, throw Sint in the mix. So what that means is that if you have a Bishop score below 5, the cervix isn't ripened and it hasn't effaced itself enough that you would be able to start labor, and so contractions will not start by themselves. Above 6, throw Sint in the mix. What this is really saying is that once this has happened, once you're above 6, you can do an artificial rupture of membrane, or you can start oxytocin for augmentation if that's the approach that you want to do. Or if it's above 6, you don't really have to do anything if you don't want to intervene. So one of the reasons it's important to understand that if you start Sint on a woman who has a closed or non-ripe cervix, that increases the risk of having an emergency C-section and an abnormal CTG. So it's important to make sure that the Bishop score is 6 or above, and that's when you can consider augmentation. Or as I said, you don't have to do augmentation as well. 4 different methods that are used that are discussed in prompt are a pessary, a balloon catheter, an artificial rupture of membranes, oxytocin infusion. And this great diagram here will tell you a little bit about like what steps need to be given, happen at what time for an induction of labor. Here are some indications for induction of labor. For instance, if there is hypertensive disorders, so someone might have preeclampsia, someone might have chorioamnitis. These are reasons why you would want to deliver the baby sooner rather than later instead of waiting for it to naturally happen. From the mother's side, there's a heap of them here. In terms of fetal post date, so after 41 weeks, it often becomes the placenta may have issues providing enough nutrition and support to the fetus or the baby. So it's important to consider whether or not you're going to induce, and also macrosomia as well, or abnormal CTGs. There are different contraindications, but some of the probably more important ones that you know is that you wouldn't induce labor for a vaginal birth if you have one of these malpresentations we've previously spoken about, and you wouldn't do it if you have a very, very bad CTG. You might not want to induce labor, you might want to go to C-section. Here are the different delivery methods in a little bit more detail. If you'd like to go through that, it explains a bit more about different induction methods. Okay, let's talk a little bit about instrumentals. So instrumental deliveries are when you use forceps or a ventouse or a vacuum to deliver. One of the important things with a instrumental delivery is the head needs to be at 0 or below, station 0 or +3. If it's above that, then it usually makes more sense if you need to deliver very quickly to end up using an emergency cesarean or an unplanned cesarean to deliver. But once it's below 0 or you're fully dilated at 10 centimeters, then you can use forceps or ventouse. The prerequisites for this to happen can be remembered by forceps, which is that you need to have a favorable position, presentation, and station. I've already talked about the station. In addition, you don't want to have a footling breech and deliver it by instrumentals, and only some breech presentations are deliverable by instrumentals, which we'll talk about in just a second. I've already said the O, which is fully dilated at 10 centimeters. We've talked about ruptured membranes, so making sure you can't if the cervix isn't favorable, and if the membranes haven't ruptured and the breaking of the water hasn't occurred, then you can't use forceps to deliver. And you also need to make sure that there's contractions happening, there's a normal appropriate CTGs in place, an empty bladder, and episiotomy as well, so making an incision to prevent tears. And it's also important to have pain relief via an epidural or a pudendal block. And scalp assessment is important as well. Fetal scalp assessment is also available. If it's available, it's very important. Then let's talk about the difference in forceps and vacuum. So usually a vacuum is used if it's a little bit of an easier extraction. Forceps are usually used if it's a more difficult extraction. In terms of which causes more injury, forceps typically cause more maternal trauma, 3rd or 4th degree tears, whereas ventouse or vacuum deliveries typically cause more fetal scalp lacerations and like neonatal jaundice, extracranial injuries, and hematomas and things like that. In terms of the different kinds of forceps, I will talk a little bit about the different kinds and how to remember them. But there's rotational and non-rotational. So rotational are Keelan's, and the non-rotational would be Wrigley's, Neville Barnes, Simpson's. And in terms of vacuums, Kiwi Cup can be used for OA, which is probably the most common. And there's also a guide to how many attempts are allowed before a cesarean is used as well. There. Let's talk a little bit briefly about VBAC. So VBAC is a vaginal birth after a cesarean. A couple of things that are important to know if this comes up on exam, and that is that the patient needs to have a continuous CTG done. You can't use prostaglandin forming inductions. You can use oxytocin, however this is a consultant-led decision. And using oxytocin to augment a VBAC is contraindicated because of the risk of uterine rupture. Some of the contraindications is if you've had more than 3 cesareans, if you've had a classical C-section, if you've had previous uterine rupture, and if you have a malpresentation, VBAC is contraindicated, according to PROM. Let's talk a bit about perineal tears. So these go from 1st to 4th degree, whereas 1st is just the vaginal mucosa has teared and often suturing is not required. 2nd, this actually goes all the way to the perineal body here, and they do need to be repaired. Once they become 3rd or 4th, these are called obstetric anal sphincter injuries. And so 3rd degree, these involve the anal sphincter, but not through to the mucosa, so they don't go all the way in past the sphincter. These obviously need to be repaired to avoid anal incontinence. A 4th degree injury, this actually involves both the sphincter and the rectal mucosa. And the risk with these is you can actually get a rectovaginal fistula, and so surgery is important. So being able to remember 1st to 4th and where they fit is useful for the exams. Now I just want to talk to you about placenta accreta and the spectrum. So this is where the placenta doesn't really sit where it's supposed to and goes a lot deeper. It's an abnormal attachment. So there's placenta accreta through to placenta percreta. And a good way to remember these is the alphabetical order they go in represents how deep they go. So placenta accreta, the most common type, this attaches to the myometrium without penetrating it, and it's the most common type. Placental increta actually penetrates into the myometrium. So I remember this as placenta increta with the IN goes into the myometrium. And percreta, I remember this as perforates, placenta percreta, and this goes through the myometrium into the uterine serosa. So two ways to remember these different stages of the spectrum. One is alphabetical, and second is the play on words based on whether it goes into the myometrium or whether it perforates through the myometrium. So discussing the management now, this is typically diagnosed at 20 weeks morphology scan, and placenta accreta is differential and must be suspected if there's an anterior low-lying placenta and it's been diagnosed in a woman with a history of a C-section. The C-section because it's more likely for this to penetrate through and go a little bit deeper because there has already been a procedure on the uterus. In terms of management, a cesarean section is targeted at 35 to 36 weeks, and could be a classical C-section if there is a low-lying placenta. And depending on when that happens, you may need corticosteroids. Let's do some questions about placenta accreta. So this is a question that helps us, cement the different kinds of depth they penetrate through, whether it's increta, percreta, previa, abruption, or vasa previa. And the answer is placental increta. And this is because it goes into the myometrium, increta, into the myometrium, but not into the perimetrium or going through. Let's now quickly talk about vasa previa. This is a problem instead with the fetal vessels when they run very close to the cervical os. So you'll be able to see here, this is where the cervical os is, and you see a lot of these fetal vessels run very close to it. The problem is that these may result in rupture, bleeding out, or fetal death. This presents with a triad of membrane rupture, painless vaginal bleeding, and fetal bradycardia, that is less than 110 beats per minute. You may see this classic sinusoidal pattern associated with this. An emergency C-section is usually indicated. And in addition, this is usually associated with a velamentous umbilical cord insertion, and that is when the cord inserts into the chorioamniotic membrane rather than the actual placenta. And because the placental vessels travel the placenta, they are unprotected by the Wharton jelly of the placenta. So that's the buzzword. If you have a velamentous umbilical cord insertion, consider vasa previa. This is often a small amount of blood, a small amount of bleeding that occurs, but it has massive effects in terms of CTG. And that is because the infant has a very small amount of blood in comparison to the mother, and a small amount of bleeding from the fetal vessels makes a huge difference rather than from the mother. So as I said before, the management is typically that this is picked up at 20 weeks morphology ultrasound, and then there's a repeated transvaginal ultrasound with a Doppler at the 32 weeks to confirm, and that's the prompt guideline. In terms of what should be done, a lot of the time the patient is admitted between 30 to 36 weeks, and a cesarean section is done before labor. So in asymptomatic vasa previa, where there hasn't been any contractions or labor hasn't started, elective cesarean section at 34 to 36 weeks is a reasonable process in an asymptomatic woman. And a cesarean section should be performed without delay in a woman with vasa previa who experiences PPROM or labour at a viable date, because at the end of the day, they must deliver and it can't be delivered vaginally. So now let's talk a little about cord prolapse. So there's two kinds of cord prolapse. There's a colt and fundic presentation. And a cord prolapse is when the umbilical cord actually lies in front or besides the presenting part through the cervix in the presence of a ruptured membrane. So the cord actually can get compressed, and that's an emergency because the baby is still dependent on receiving that cord blood. This is quite rare, but happens around 0.5% of births. Now, this is often seen in presentation abnormalities like breech presentation, transverse fetal presentation, if there are multiple pregnancies, twins, triplets, etc., or whether there's some abnormal fetal movement due to too much or too little amniotic fluid, as well as premature birth. Some clinical signs will be that there is an abrupt change in previously normal CTG, and there'll be severe decelerations or fetal bradycardia that have occurred around the time of rupturing of membranes. And on vaginal examination, there'll be a thick pulsating cord that is present and viewable. Now, there are two different kinds, as I said, two different kinds of prolapse. The first is occult, and this is when it runs alongside the presenting part, as you can see here. And the second one is overt, which is when it's over the top of the presenting part. So management of cord prolapse can occur via the cord mnemonic. It's a good way to remember it. So the first thing is to always be considering a prolapse. So during every intrapartum vaginal examination, if you see any abnormal CTGs, after any rupture of membrane, these are all times to think about this as a differential. If there are signs of a cord prolapse, you want to organize help with a code green and organizing immediate time to do the birth in theatre. You want to relieve the pressure on the cord. So you want to put the patient in the left lateral position and prevent any cord compression. So what you can do here is you can actually elevate the presenting part. So if there's a head, you would try and move the head up a little bit, and you would just use your fingers, but you don't want to touch the cord. And you can also use an IDC to fill the bladder with saline to push the presenting part away. Of course, you want to try and discontinue giving any more uterotonics, and you might want to consider tocolysis if there's CTG abnormalities to stop any uterine or to minimize uterine contractions. Then this is a Cat 2, usually C-section, so within 60 minutes if there is a normal pattern, and it would be Cat 1 if it was a very, very bad CTG scan. The PROM says that vaginal delivery can be attempted at full dilation if it's anticipated that a birth will be accomplished quickly and safely. So if it's quicker just to deliver vaginally, that could be done instead of going to theatre, but it really would depend on the clinical situation. So that concludes our presentation on some of the more difficult areas of obstetrics and obstetrical bleeding. I hope you have taken something away from it. We would love your feedback, and I would encourage you to follow us for the remaining MOGIG videos in this series. Thank you.